This is a dilated cardiomyopathy. I guess most of you will recognize the diagnosis from this simple four-chamber view. But it's not always so easy. And as you will see in this lecture, there are many different features aside from those that can be seen in this image. Now, the definition of a dilated cardiomyopathy is we've got a primary myocardial disease with impaired systolic function and, at least in most patients, a dilated left ventricle. But dilated cardiomyopathy can present in very many different ways. It's a very colorful picture that you have with respect to the way the echo looks, with respect to the prognosis, and also with respect to the cause. But what are some of the facts that we have to look into? First of all, most patients present in the age group of 20 to 60 years, but we can even find infants with dilated cardiomyopathy and sometimes patients who are very old. The presentation can sometimes be as an incidental finding. Patients come because they are symptomatic, usually dyspnea. Sometimes the first presentation is actually sudden cardiac death and the patients are brought to the hospital as a survivor of sudden cardiac death. And as I already mentioned, the cause is very variable and so is the prognosis. Let's take a look at George. This is George. He never really had any symptoms. He just went to the doctor to get a normal medical checkup. They found an abnormal ECG with very minor STT segment alterations, and then they performed an echo and they found this here. I guess you will realize that the left ventricle function is diffusely reduced. And if you look at the four-chamber view, you can really appreciate that the ventricle is dilated. Now, the patient did not have any symptoms. Now, George is certainly going to ask the question, what is going to come out of me? There are very many different options. First of all, left ventricle function can normalize completely and he will have a completely normal prognosis. Maybe he will develop progressive heart failure very quickly or have a chronic phase where he's rather stable and then develop heart failure at a late stage. Maybe he will develop cardiomyopathy-associated problems, and there's many of such problems as you will see in this lecture, and possibly he would just drop dead and have sudden cardiac death. So all of these options are something that you have to consider, and every patient has a different course. And echo can help us in a certain way to look how the patient will develop, and we will also be able to look at the stage of heart failure that the patient is in. The next question that George is going to ask you is, why do I have cardiomyopathy? Now, if you go into the literature, you will find very many different causes. But one thing is clear. In most cases, we simply do not know. We have what we call idiopathic dilated cardiomyopathy. Now, this does not mean that there is not a cause for cardiomyopathy. It just means that in many cases, we're not going to extremes to really find out. Because to find out, we'd have to use myocardial biopsy and look at whether or not, for example, it's some form of myocarditis or if there's some immunological problem that underlies the problem. But in general, we can say that probably many patients, many more than we think, do have a myocardial infection as a cause for dilated cardiomyopathy, and that probably there is also some immunological causes of cardiomyopathy which are more frequent than we actually know. But here is a list of other potential causes. For example, ischemic heart disease, infiltrative disease, peripartal cardiomyopathy, hypertensive heart disease, HIV infection, connective tissue diseases, substance abuse, and chemotherapy, for example, doxorubicin, but there's many other causes as well. Now, I already mentioned that ischemic cardiomyopathy is also a cause of dilated cardiomyopathy. By definition, it's a different disease entity. But we sometimes throw it into the same bag because they share very similar features and because they're sometimes very difficult to distinguish from each other. In general, we consider an ischemic cardiomyopathy if we have an obstruction of the coronaries of more than 50%. But this too is a very crude definition because remember, sometimes we have thrombotic occlusion of a coronary artery, and once the thrombus is gone, we might not even see an obstruction. For me, the definition is if we have multiple infarcts and where we have a remodeled left ventricle, which essentially at the end looks very much like a classic dilated cardiomyopathy. Heart failure is the major sequel of dilated cardiomyopathy, and it's a big burden. Let's take a look at some facts. Well, 26 million people have heart failure. 17 to 45% of patients who are admitted with heart failure die within 1 year. We have approximately 46,000 hospitalizations in the US, and there's an increase in prevalence of this disease. And finally, it's also very expensive. It costs us approximately $108 billion per year. But what does it mean for the patient? Left ventricular heart failure always initiates a domino effect. What does that mean? Well, it eventually leads to pulmonary hypertension, also to right heart failure, and then the patient really is into problems. But let's take a closer look at the pathophysiology of the disease. So at the beginning, we've got systolic dysfunction. This leads to an increase in left ventricular filling pressures, which translate, of course, to the pulmonary circulation. So we've got pulmonic congestion with the classic symptoms of dyspnea and eventually even pulmonary edema. This means that we have a high pressure in the right heart system, in the right ventricle. And this, in turn, of course, can lead to right heart failure. This then initiates, because we have a dilated right ventricle, tricuspid regurgitation, which is not good because it too is a burden to the right heart and can lead to an even further decrease in right ventricle function. But there's another vicious cycle. Systolic dysfunction leads to a dilatation of the left ventricle, and this dilatation of the left ventricle causes what we call functional mitral regurgitation. And functional regurgitation, again, leads to further impairment of systolic dysfunction and to a further increase in the filling pressures, also not good for the patient. And then we've got another vicious cycle. Because if we have systolic dysfunction in a dilated left ventricle, very frequently we will also have dysynchrony, a left bundle branch block. And this left bundle branch block, again, can deteriorate systolic dysfunction and lead to an increase of filling pressures. So be aware that we're going to see some of these problems in our patients. Dysynchrony, left bundle branch block, atrial fibrillation because we've got a dilation of the left atrium due to either regurgitation or to the elevation of filling pressures. Mitral regurgitation, also already mentioned. Tricuspid regurgitation, as in this patient who also has a pacemaker, which is an additional, of course, trigger for tricuspid regurgitation. Thromboembolism, you'll see examples of this in this lecture. And even renal failure, which again is not good for the heart because then we have a disturbed fluid balance, which is also not good for the ventricle. Okay, so now in the next chapter, we'll take a look at the true echo features that we'll be expecting in these patients.